Hi everyone. So today I'm going to be presenting on septic shock and the use of inotropes within septic shock. So firstly, we first have to define what septic shock and sepsis is. So sepsis refers to the presence of two or more of the criteria for a systemic inflammatory response syndrome in a patient who has suspected or proven infection. Septic shock then refers to the presence of sepsis combined with cardiovascular dysfunction, despite the administration of at least 40 mL of isotonic fluids in an hour. Here, when we talk about cardiovascular dysfunction, we're talking about the presence of hypotension, prolonged capillary refill time, oliguria, metabolic acidosis, or elevated arterial lactate. Technically, having two of any of those will classify a patient as being in septic shock, or having hypotension alone is classified as having cardiovascular dysfunction. And then lastly, severe sepsis. So this is dysfunction of at least two or more organ systems and cardiovascular functions respectively. So this slide is just to recap us on what exactly defines a surge response. So obviously in pediatrics it's a little bit different because you have to consider the different parameters for each age group. But basically we're looking at the heart rate, the respiratory rate, the leukocyte count, and the systolic blood pressure. We can classify it into those who are newborn, infants, toddlers, school age, and adolescents. And in heart rate, we're looking at the presence of tachy or brady. In the respiratory rate, elevated respiratory rate. In the leukocyte, more than these particular numbers in that age group. And then systolic blood pressure, we're looking at hypotension, so less than that particular systolic blood pressure. The development of septic shock is associated with a high degree of morbidity and mortality. That's why the initial goal of management of sepsis is focused on a time-sensitive approach that focuses on rapidly recognizing patients who have infections or severe sepsis and are therefore at high risk of developing or progressing to septic shock, or recognizing those who are already in septic shock. After this recognition, one needs to then proceed to rapid clinical assessment of these patients and therefore rapid initiation of resuscitation. Many institutions and publications recommend developing protocols or algorithms that are aimed at identifying patients who are at high risk of developing sepsis and septic shock. These high-risk patients include those with immunosuppressive conditions like malignancies, in our population in particular, patients who are RVD positive, as well as patients who are post-op, like the many post-op cardiacs we tend to see in our ICU, as well as malnourished patients as well, who are often immunocompromised. It's also obviously important to clinically look at your patient, looking at objective markers such as vital signs. What's important to remember is that in the pediatric population, drops in blood pressure are often a late sign of sepsis. Rather, it's important to look at the clinical picture as a whole, and some papers have identified that heart rate is actually a very sensitive marker of sepsis, although non-specific, as it can rise due to many conditions like anxiety. One should never ignore patients who develop unexplained tachycardias, and these can be early signs of sepsis. And then, of course, doing a thorough clinical exam, looking for signs of shock. For example, delayed capillary refill, the color of the skin, decreased or weak pulses, as well as the mental status of the patient. In pediatric populations, obviously a lot of them won't be orientated, particularly in the younger populations, but we can look for things like irritability, inappropriate or inconsolable crying, as well as poor interaction or lethargy in these patients as early signs of sepsis. It's also obviously important to do a full body examination of your patient and expose them properly, especially to look for skin change that we might miss if we didn't do that. In particular, looking for things like petechiae, like non-blanching petechiae that might be seen in a meningococcal sepsis, or this macular erythema that might be seen in signs of purpura might be seen in patients who have developed coagulation issues like DIC. and then also looking for conjunctival infusions, which may be seen in patients who are in shock. Doing a thorough examination not only identifies signs of shock, but may help you identify the source of the sepsis as well, which can help you with early source control. Additional signs and symptoms you might want to look at are signs of dehydration, which may be seen in patients who have acute gastroenteritis, rigors, decreased tone, seizures, meningism, which may be associated with the meningitis. If the source of sepsis is from the lungs, respiratory depression or failure, pulmonary rales, decreased breath sounds caused by BPN. A patient may have a distended or tender abdomen or renal angle tenderness if they have a pyelonephritis. And of course, something we don't often look at is looking for the joints. So looking for warm swelling and erythema of the joints may suggest an osteomyelitis or a septic arthritis. Again, looking at the skin is very important. So looking at signs of local infection like skin abscesses, particularly in sites where one has invasive indwelling catheters or invasive lines. And then looking for specific signs of certain sepsis. For example, in staph sepsis, one might get these skin nodules, which are associated with disseminated Staphylococcus aureus infection, or particular signs, for example, this gangrenosum, which is caused by Pseudomonas infection. Now that we've recognized early signs of shock and done a thorough investigation on our patient to try and pick up sources of their sepsis, we can then move on to research. In the many publications and revisions that have been done to protocols with regards to treating sepsis, what has often been mentioned is making sure that a patient receives antibiotics within the first 60 minutes of you identifying and recognizing that they have severe sepsis or septic shock. With the resus of septic shock, the quicker the correction of the deficits, the better the outcome. Practically, what this means is that once a patient is recognized to be in septic shock, one should establish rapid IV access. This access should be established within 5 minutes of you seeing the patient ideally, and 2 IV lines are preferred with as large a bore or as large a cannula as you can within that patient. If one is struggling to get IV access through a peripheral line, going into interosseous is often recommended. Once an IV line has been established, it's then important to start appropriate fluid resuscitation. We'll get to what it means to start appropriate fluid resuscitation in the next few slides. But basically what you're trying to establish within this time is whether a patient is fluid responsive or not fluid responsive, as well as correcting their fluid deficit that is as a result of their sepsis. Then comes the initiation of antibiotics. Obviously, within the first hour of identifying that the patient has sepsis, often what we initiate are broad-spectrum empiric antibiotics, which will then be downscaled or tailored once we have appropriate cultures that have been taken, which of course means that cultures should be ideally done at this time as well. And then within that 60 seconds, as I said, one should then identify if the patient is fluid responsive or not. And if we've identified that they are not fluid responsive, then within that hour, one should also initiate inotropic support. Once resus has begun, it's obviously important to know when to end resus. For this, we can look at our therapeutic endpoints. So some of the things we can look at are, for example, the quality of the central and peripheral pulses. We can look at skin perfusion. Has the patient returned to having warm peripheries with a perirefill time that's less than 3 seconds? We can look at the patient's mental status. If they were previously lethargic, are they now active? If they were previously obtunded or irritable, are they now consolable? Or have they returned to a normal mental status? In kiddies, it's often a good idea, particularly when you're initiating resus, to have a catheter in place or a way of measuring our urine output. And we're looking for a urine output of greater than 1 ml per kg per hour to let us know that effective circulatory volume has been restored. We can also look at our blood pressure. In particularly, we want to make sure that the blood pressure has returned to at least 1/5 of the percentile for that patient's age. If we have blood gases available, which might not be in some peripheries, or rather peripheral hospitals, we can have a look at the serum lactate. We are aiming ideally for a serum lactate of less than 2. Lastly, if we have central venous access available, we can then look at their central venous oxygenation, which we're aiming for it to be above 70%. What must be remembered is that you have to tailor these therapeutic endpoints to your particular patients. So, for example, in our ICU unit, we often see a lot of congenital cardiac patients, in which case we might never achieve, even with good and adequate resus, a central venous oxygenation of greater than 70%. We might never achieve pink peripheries if they're cyanotic or they're mixers, etc. So you do have to tailor these to your patient. So, as with any resus, one should not forget their ABCs. These were just some important points I thought to mention that might be different or things to take note of in patients with septic shock. So initially, when resuscitating a patient with septic shock, particularly if they're desaturating, one needs to give as high a percent of oxygen as we can, so usually 100% supplemental O2, to optimize oxygen content and perfusion to the tissues. Once the patient has improved and the previous period of instability is over, then we can start to titrate our saturation so that they don't go above 97%, and this is obviously to prevent the damage that can often come with increased free radicals that come with higher oxygen, with higher saturations. To monitor this, simple pulse oximetry as well as ABGs if they're available are good enough. Then, with regards to intubation, often patients who have septic shock need intubation. This is for a number of reasons: to protect the airway if they're obtunded, to assist with ventilation, to improve perfusion to the tissues, and to reduce the work of breathing. The thinking behind this being that a decreased work of breathing means less diversion of the cardiac output to the respiratory muscles, and therefore more of the cardiac output can go to other tissues in order to improve their perfusion. In terms of intubating patients with septic shock, an RSI is often the preferred method. What's important to note, though, is that patients who are in septic shock are hemodynamically unstable, often. So therefore, we need to consider the fact that the addition of intubation might further worsen their hemodynamic instability. Therefore, we need to try and make sure that we optimize the patients, if possible, prior to intubating. This might mean additional fluid support, going on to inotropes early, or in younger kiddies, even giving atropine to counteract the reflex bradycardia. Ketamine is often a choice drug for the induction and sedation with regards to intubation. Previously, etomidate was recommended because of the supposed hemodynamic instability that is associated with etomidate. But some small observational studies have found that giving etomidate might be associated with an inhibition to cortisol formation during sepsis. So therefore, some publications are now not recommending etomidate. One can also think about giving fentanyl in small doses as it's short-acting in order to sedate patients, particularly in the younger populations, those who are less than 3 months. And then short-acting barbiturates and propofol should ideally be avoided, as they can actually tank your BP in patients with septic shock. So moving on to our C for circulation. So with sepsis, the shock is often distributive. This means that the patient has a relative intravascular hypovolemia, which means that they often need very large amounts of fluid in order to correct their deficit. The major goal for the initial treatment is restoring adequate tissue perfusion, which will obviously be based upon the therapeutic endpoints that we discussed earlier. We've already discussed IV access, but basically 2 sites is preferred, the largest caliber you can, establish within 5 minutes, and if you can't get a peripheral up, then proceed straight to IO. With regards to fluid resuscitation, it's often recommended that we give between 40 and 60 ml of fluid at a time. What's been found, though, is that patients who have distributive shock often need very large amounts of fluid and can need up to about 120 ml per kg of fluid before we've actually corrected their deficit. Before we've actually corrected their deficits. It's preferred that we give crystalloids over colloids, and it's also preferred that we give balance buffers as opposed to agents like normal saline, which might cause in large amounts hypochloremic acidosis. In terms of how we give the fluids, the infusions need to be in small aliquots that are done rapidly, so often over 5 minutes at about 10 to 20 mils per kg at a time. You can do this with the manual push and pull method, or if you have an infusion or a syringe pump, to do it with a syringe driver instead. What's critical though is that before and after each push that we assess the patient. What we're assessing for is signs of fluid overload and signs of continued inadequate end organ perfusion. Signs of fluid overload would be, for example, an enlarged liver, a gallop rhythm, the development of edema, and it's particularly important to assess for these things in patients who are at risk, so patients who are in cardiac failure and patients who are malnourished, because they can often be pushed over very easily with large amounts of fluid, which can make their symptoms worse. Ideally, within the first hour of treatment, what you're trying to establish is the patient fluid responsive or are they fluid refractory? Patients who are fluid refractory can then be started on rapid inotropic support tailored to whether or not they have a warm or cold shock. Some key points to mention though with regards to circulation, some of them we've already spoken about, but basically crystalloids over colloids, and this is because colloids have been shown to have a lack of clear benefit over crystalloids and are often cost a lot more than basic crystalloids. Some studies have shown though that it may be reasonable to give a colloid infusion if after giving 60 mils per kg of a crystalloid fluid, the patient still hasn't improved, or they are known to have a hypoalbuminemia, so an albumin of less than 3 grams per deciliter, sorry, those are American units, or patients who have patients who have already developed a hypochloremic metabolic acidosis. Some of the dangers though that are associated with colloids are that they have an increased risk of acute kidney injury, coagulopathy, and they've shown to cause death in adults with severe sepsis or septic shock, particularly if they're given in large volumes. So those are volumes more than 15 mils per kg. And then, as we said, it's important to establish ongoing tissue perfusion, and to do this you might need invasive monitoring, particularly in ICU settings. Fortunately, that's often already set up. And then, as I spoke before earlier, in resource-limited settings, it's very important to note that in places that can't provide advanced airway and circulatory support to deal with the complications of fluid overload, children who have signs of compensated shock, so they are not hypotensive, and severe febrile illness without the dehydration or hemorrhage, who receive rapid bolus administration of albumin or normal saline, may have increased mortality. So these are kids particularly who have malaria or high frequency of parasitemia, have severe anemia, so HPs of less than 5, who are malnourished, and those who have cardiac lesions. So these kiddies really need to maintain a high suspicion for fluid overload, maybe consider doing slower infusion and doing constant assessment to see if they've developed signs of fluid overload. All right, and then some other basic supportive things to check. So we're going to be checking for hypoglycemia and hypocalcemia. So those who have hypoglycemia, it should be corrected with rapid IV infusions of dextrose. It may need a continuous dextrose infusion, and we need to be constantly checking to make sure the blood glucose is in a safe range. Also important to remember that patients who have signs of septic shock may have increased risk of developing adrenal insufficiency, and being hypoglycemic may be one of the first signs of this. And also it's important to note that we can allow permissive hyperglycemia in patients with sepsis, and we should be avoiding insulin in patients with sepsis. And then patients with sepsis often have hypocalcemia, which may need to be corrected if it's less than 1.1. So these can be corrected with calcium gluconate, 10% solution, at doses up to 50 to 100 milligrams per kg by IV or IO infusion over 5 minutes. It should be administered into a large vein and should never be mixed with Sodolic. With regards to nutrition, enteral nutrition is often preferred, and it's often advocated to avoid parenteral nutrition in the first 7 days of admission. The Surviving Sepsis campaign also suggests against withholding feeds solely based on inotropic administration. So therefore, just because a patient is on inotropes doesn't mean that they can't feed, as long as the patient has been adequately fluid resuscitated, you're not escalating the inotropes, and they're otherwise hemodynamically more stable. Antibiotics and sepsis. So, antibiotic administration. Your goals of management with antibiotic administration is basically source control. So, we have to identify the source of sepsis and treat that source or the underlying sepsis in order to adequately treat septic shock. All your other interventions, the fluid rehydration, nutritional support, airway and breathing, are all supportive, and they're not aimed at actually treating the cause of the sepsis. So therefore, this is probably your most important therapeutic intervention. In terms of the timing, antibiotic therapy, as mentioned, should be initiated particularly within 1 hour of identification of sepsis. If you can, you should be obtain appropriate cultures, but one should never delay the administration of antibiotics in order to obtain cultures or in order to do LPs. And as mentioned before, ideally 2 ports of access in terms of IV access are recommended. This is so that one can be dedicated to antibiotic administration and the other can be dedicated to fluid resuscitation and septic shock. And most importantly, each hour one delays antibiotic administration has been shown to be associated with approximately an 8% increase in morbidity and mortality for these patients. So choosing an appropriate antibiotic can often be quite tricky, particularly in critically ill patients who've been in hospital for a very long time. The choice of the antibiotic often dependent on the child's age. For example, we don't choose the same broad-spectrum antibiotics in neonates that we do in older children. The history, their associated comorbidities, their clinical syndrome, how long they've been in hospital, the hospital local resistant patterns, etc., etc. It's often important in patients, particularly if they've been in hospital for a long time, to cover for MRSA. If we need to cover for enteric organisms, if there are clinical symptoms that suggest that the source could be genitourinary or gastrointestinal in nature. We can treat for Pseudomonas if the patient is is immunocompromised, and then in kiddies, neonates rather, considering things like Listeria and HSV might be important in your consideration of what antibiotics are appropriate in this age group. The Surviving Sepsis campaign also recommends against the use of multiple antibiotics that target the same pathogen, advocates very strongly for source control. So if a patient has lines in situ when they develop their sepsis, taking those out. If there is local sepsis from a wound, making sure that that's been debrided or cleaned, etc. And then also obviously frequent reevaluation of whether or not the patient has sepsis. So this will mean frequent reevaluation of the patient and then frequent reevaluation of the cultures to see if we've grown anything and whether we need to stop antibiotics, escalate them, or target them to the appropriate, de-escalate and target them to appropriate organism. And then of note, just from a practical point of view, antibiotics which can be given with a rapid IV bolus, for example, your beta-lactam agents and your cephalosporins, should ideally be administered first, then followed by infusions of antibiotics such as Vanco that maybe have to be delivered more slowly. So these are just some regiment examples that I thought might be useful in trying to figure out which empiric antibiotics one might initiate. I'm not going to go through all of them, but basically you can class them into patient's age group, whether or not they're immunocompromised or not, whether or not they have allergies to certain medications, and then some particular things I thought were important to point out. So like we've already said, In the neonatal populations, look for hepatic lesions because you might have to start some acyclovir. Look for other sources, for example, genitourinary or gastrointestinal sources that might need to consider starting an aminoglycoside in some patients. And then also very important is looking for patients who are at increased risk of fungal sepsis, particularly patients who are immunocompromised, who are not responding to your antibiotics, patients whose platelets drop, or patients who have an identified fungal source. And these patients, we can then add something like amphotericin B or an echinocardin like mycofungin. All right, and lastly, inotropic support. So we said it was very important to assess within the first 60 minutes whether a patient is fluid responsive or not. If they're not fluid responsive, then it's very important to initiate inotropes early in order to support the patient. So inotropes are frequently necessary in the initial resuscitation of a child with septic shock, and this is just to sustain the perfusion and make sure that we don't have organ compromise. The Surviving Sepsis Campaign recommends that inotropes be administered within 60 minutes of presentation if there is no response to at least 60 mL per kg of fluid boluses, or if the patient develops fluid overload while you're giving your boluses. And then in terms of giving your inotropes, it's often preferred that we give them through central venous access, but if you haven't established that yet, you can start giving them with peripheral access and then later establish central venous access for inotropes. You shouldn't delay your inotropes just simply because you don't have central venous access. All right, so in terms of inotropic support, I found it useful to classify shock into warm and cold shock. Some publications recommend not doing this, but just in terms of conceptualizing why we might give certain inotropes in certain situations, I just found this was the easiest way of trying to conceptualize that or describe that. So in terms of warm shock, what we mean are these are patients with your classic distributive shock. They are hypotensive, but you find that they have bounding pulses, they're flushed or pink extremities, and they have these flash capillary refills. In these patients, your primary problem is that you have these leaky dilated capillaries. What we need here is to get adequate systemic vascular resistance so that we can have better perfusion to our peripheries. In this case, therefore, we need a potent vasoconstrictor, and that is why noradrenaline is often your first line inotrope in these patients. So your noradrenaline infusion may start at 0.03 max to 0.05 max per kg per minute, and then you can titrate it up to effect. However, if the patient remains hypotensive, or if you find they're having an inadequate response to this, or you're using high doses of noradrenaline, there's no problem with starting an additional agent like adrenaline. And obviously these should be monitored by your therapeutic endpoints and your cardiac index as well. And just to reiterate, the mode of action of the noradrenaline is that it's a potent vasoconstrictor, and it acts on alpha-1 and beta-1 adrenergic receptors and only has a moderate increase in cardiac output, and therefore counteracts a lot of the vasodilatory effect that's seen in patients with classic septic shock. Then moving on to cold shock. So cold shock is quite the opposite. So in these patients, you have inadequate perfusion, they have weak pulses, cold distal extremities, and prolonged cap refill. So these are patients who sort of have your classic hypotensive hypovolemic shock. In these patients, you want something that has increased inotropy, increased chronotropy, so therefore adrenaline is often the point of call. Adrenaline is often the point of call in these patients, and to be quite honest, the majority of your shock patients, even with septic shock, will actually be patients with cold shock, and therefore if you're undecided about which inotrope to use, often a lot of publications recommend starting with adrenaline. Your doses can be somewhere at 0.05 to 0.1 mics per kg per minute, obviously titrating these up to effect. Once, though, you're reaching high doses of about 0.1 mics per kg per minute, then you might consider adding a second agent, also noting that your alpha-adrenergic response of adrenaline will be more pronounced. So therefore, the systemic vasoconstriction may be more evident. And if you're struggling with perfusion to certain organs, or maybe if this, for example, patients who don't run restricted perfusion, so for example, a post-op gastric patient you've just done an anastomosis on, adrenaline at high doses might not be the right agent to give in these patients. So therefore, you can add a second agent to try and increase your support. Adding noradrenaline is a good idea. Substituting adrenaline with dopamine can also be done as well, and may be a good alternative to epinephrine in these cases. And in this case, you might give it and titrate up to effect about 10 mics per kg per minute. And then if your catecholamine, if your inotropes that depend on catecholamines are not working, one can also consider adding vasopressin as well, that some studies have found. And then lastly, just a point on catecholamine-resistant shock. So some patients, despite your inotropic therapy, despite your fluid resus, despite your inotropic therapy, might not respond still, and their shock might persist. In these patients, you need to think about something like adrenal insufficiency, particularly if they're at risk of absolute adrenal insufficiency, like patients who have purpurofalmonins, those who had chronic treatment with corticosteroids, and those who have hypothalamic and pituitary abnormalities. And these patients might need stacked doses of hydrocortisone. So the hydrocortisone would be given at 50 to 100 mics per kg per day, 100 milligrams, per square meter per day, which is approximately 2 to 4 milligrams per kg per day in intermittent doses. And then also, if they're not responding to your inotropes, they're not responding to fluids, also you then obviously need to go back and reassess your patient. You need to assess if the underlying comorbidities that you've missed, maybe an underlying pneumothorax, an underlying pericardial effusion, maybe intra-abdominal hypertension, ongoing blood loss that you may have missed. And for these, you can do investigations like your ultrasound of your lungs, heart, and your abdomen, which may help you identify why your patient isn't responding to either inotropes or fluids. So this is a resus algorithm that was developed by the Surviving Sepsis Campaign that was updated in February 2020. And this is just basically a summary of the entire talk that we've had. So basically from the beginning, if you suspect a patient has sepsis or if you identified signs of septic shock, time is of utmost importance. What you need to do is make sure that you obtain good IV access within 5 minutes. If you can, collect your blood cultures or do your LPs, but never delay your antibiotic therapy to do this. You need to start them on appropriate broad-spectrum antibiotics within an hour of your recognition of your septic shock. You need to make sure that you administer adequate fluid resus or adequate fluids within that hour. You need to measure their lactate if you have it available, and within that 60 seconds you need to decide if this patient is fluid responsive or not, and decide whether or not you're going to have inotropic